On that these sessions are recorded. As we go through the presentation, if you have questions, please feel free to drop them into the chat, or please save them for the Q&A session at the end of the presentations. So I want to start by introducing our very own Liz Breitenstein. Liz is part of the Healthcare Associated Infections Program, where she leads antimicrobial stewardship initiatives for us. Her work focuses on improving antibiotic use across healthcare settings through a combination of data analysis, education, and development of tools to support frontline healthcare teams in their effort to deliver safe and effective care. So welcome, Liz. We're delighted to have you share your expertise with us. And I understand you're going to run your own slides.
Yes, thank you, Therese. If you want to just give me a thumbs up when my slides are showing, or if they're showing.
They are showing.
Okay, great. Hi everyone. Thank you for that lovely introduction, Therese. Thanks for having me. So really, before Dr. Jump presents, I just wanted to highlight why antibiotic stewardship, especially around urinary tract infections, urinary tract issues, is so very important. So, why is it important to get antibiotic prescribing right? I think probably most everyone on the call knows that antibiotic resistance is an increasingly dangerous issue for patients. Decades of antibiotic misuse have resulted in bacteria that are increasingly resistant to and sometimes impossible to treat. We know that resistant infections lead to longer hospitalizations, worse outcomes for patients, higher costs. And you can see the statistic here that in the US each year, antibiotic resistant bacteria and fungi cause an estimated over 2 million infections and over 35,000 deaths. So a really, really significant issue in the United States. And looking specifically in Oregon, we can see here that carbapenem-resistant Enterobacterales, or CRE cases in Oregon, have really been steadily increasing year to year. And CRE infections are so significant and something that OHA tracks because those carbapenems, as many know, are really the broadest spectrum antibiotics that we have. They're used to treat really severe infections. And as that resistance increases, it really leaves us with not great options to treat patients, right? The antibiotics then that we're left with can be some really risky ones with toxic side effects. And it becomes more and more of a challenge to treat these infections for patients, and we have less and less effective treatments. And again, looking at some Oregon data around these carbapenem-resistant Enterobacterales infections, we can see that in Oregon, there are much higher rates of CRE in older adults and in females. And importantly, we also know that asymptomatic bacteriuria, that Dr. Jump will be digging into much more deeply, and that's the presence of bacteria in urine without clinical symptoms of urinary tract infection. But we know that that's more often treated in women and in older adults. So that's, I think, a significant connection here with the number of resistant infections we see in Oregon and who we're seeing them in. And then I just wanted to touch on a couple different care settings. So, how big of a problem is antibiotic use in long-term care facilities? I know a lot of folks on the call have heard this from me many, many times, but we know that an estimated 50 to 70% of long-term care residents will be prescribed one or more courses of antibiotics each year. And in nursing homes, small studies have shown that an estimated up to 75% of antibiotic prescribing for urinary tract events is inappropriate. So we know it's a known issue and something we need to work to improve. But long-term care facilities are not the only care setting where it's a problem. A study by the Offices of Rural Health in Washington, Oregon, Idaho, and Utah found that inappropriate diagnosis and treatment of urinary tract infections is really a common issue in critical access hospitals. They found that of patients with positive urine cultures, 35% with no documented urinary tract symptoms, so no clinical symptoms, but a positive culture, were treated with antibiotics, and that, yeah, 75% of those patients were treated for asymptomatic bacteria. Sorry, I fumbled that, but but 35% of the patients that had the positive urine culture and no symptoms. So we know that, there are plenty of patients that are having positive cultures with no symptoms, and out of those, patients are being treated with antibiotics. So completely unnecessary use of antibiotics. And, beyond resistance, so I feel like I really, talked a bit about resistance, and I spend a lot of time talking about antibiotic resistance, but there are other reasons that we want to be careful about antibiotic use. That there are risks associated with antibiotic use, both for individual patients and residents and at the facility level. We know that unnecessary antibiotic therapy can lead to adverse drug reactions, from C. diff infection to the development of antibiotic resistance to allergic reactions, and a whole host of side effects. And then there are also facility level risks that I think we're learning a lot more about. We know that high rates of antibiotic use in long-term care facilities are associated with increased adverse effects among all the residents. So not just those receiving antibiotics, but all residents of high-use facilities. There was a 2011 study that looked at over 100,000 residents across 600 nursing homes, and found that residents in high antibiotic use facilities had up to a 24% increased risk of experiencing antibiotic-related adverse events. So even if they themselves had not received antibiotics, so things like C. diff and drug-resistant infections just become more pervasive in these higher use facilities. So it's not just a risk for folks and patients taking antibiotics, but for those facility community at large. And then, of course, there are operational and cost implications of unnecessary use. When it's completely unnecessary, there's associated cost of PPE and staff time for enhanced infection control measures, increased drug costs, and lots of increased systemic costs, especially when we're looking at antibiotics that are completely unneeded. So I wanted to touch on this topic of stewardship that I know a lot of folks have heard me talk about before, but kind of the intersection between antibiotic stewardship and diagnostic stewardship and how they sort of work together, right? So the principle of antibiotic stewardship is that we ensure antibiotics are used only when they're needed, that we're selecting the best drug at the right dose for the right duration. And I kind of put some questions down here that clinicians will be thinking about when it comes to antibiotic stewardship, right? The things that we should ask ourselves, does my patient have an infection in the first place, or an infection that requires antibiotics? What empiric therapy is appropriate? Where should I start? Am I using the narrowest spectrum antibiotic that's appropriate once I get cultures back? And really importantly, when can I stop antibiotics, and should I stop antibiotics? And this intersects with this concept of diagnostic stewardship. So diagnostic stewardship is, ensuring that we're using tests appropriately to avoid misdiagnosis, overdiagnosis, overtreatment. And really importantly, the way we test affects our treatment decisions and can lead to prescribing when an antibiotic is not needed, or failure to prescribe if an antibiotic is needed. So really, really important. Obviously, both cases can negatively impact patient health. And the kind of questions I think about when I think diagnostic stewardship is, when I have a patient, should I order a test to determine if my patient has an infection? Really importantly, will the results of this test change my treatment decision? If it's not going to change the way I treat the patient, is the test necessary? What test is appropriate? Which would be the right test to select? And how do I appropriately collect and store specimens? So just kind of those questions that all intertwine as we treat patients that have suspected infections. And again, knowing that stewardship supports safer, more effective care. We also know that UTI testing and treatment are are common areas of misuse and overuse and issues that I know that a lot of facilities are working on and struggling with getting right. So I don't want to take up any more of our time. I'm really excited to hand it over to Dr. Robin Jump to share her expertise on this.
Thank you, Liz. Yeah, I'll just take a moment and introduce Dr. Jump. Dr. Jump is the Associate Director of the Tech GREC program at the Veterans Pittsburgh Healthcare System and an Associate Professor of Medicine at the University of Pittsburgh. She's an infectious disease physician with a research program focused on antimicrobial stewardship, particularly in post-acute and long-term care settings. She's also very interested in using telehealth to improve the care of older adults. And she has a research funding from the VA, CDC, and ARC, and has published extensively in peer-reviewed journals. Dr. Jump has served on committees with the Society for Post-Acute Long-Term Care Medicine and the Society of Hospital Epidemiology of America, or SHAE. So with that introduction, I will hand it over to Dr. Jump. Welcome.
Thanks so much for having me. I really appreciate the invitation. It's an honor, and thanks also for the kind introduction. Are you seeing my slides or presenter view?
Your slides.
My slides. Okay, excellent. I've got a bizarre view on my screen, so thanks for letting me know. And I also want to thank Liz, because I think she hit all the highlights, and so everything after here, besides the title, is extra messaging, but I think you've already heard the take-home messages for the day. So let me start with my necessary evils, which are apparently to first advance my slide. There we go. Whoops. All right, I'm a little bit out of sync here. So I have no direct conflicts of interest relevant to this presentation. I take money from whoever is happy to give me some to do some good science, and now more than ever, the opinions here are my own and do not represent necessarily those of the VA or the federal government. So learning objectives. We'll talk about recognizing signs and symptoms of acute cystitis, as well as other reasons for those symptoms. We'll talk through interpreting and responding to results from urinalyses and urine cultures, and we'll discuss management of individuals with acute cystitis. So let's start with a case, Mr. N. This is not really a picture of Mr. N. He's a 73-year-old male who was admitted to the nursing home on January 5th for rehab following surgical repair of a broken femur. He has chronic pain. He's been on opioids since 2007. He's got lower urinary tract syndrome, or LUTS. He's got diabetes that's reasonably well controlled. He has chronic kidney disease, and he has coronary artery disease. So on the 10th, so 5 days after admission, the nurse notes that he's got dysuria. So the night coverage for the nursing home orders a UA and culture, and the UA comes back with a specific gravity, or SG, of 1.023, too numerous to count, TNTC white blood cells, and 3 to 10 red blood cells. On the 12th, the culture comes back showing greater than 100,000 Klebsiella, and the covering provider on that day, so now 2 days later, orders 8 days of cefuroxime. There are some troubles here, and we'll come back to it. But first, let's go through some of the material. So you have probably all heard of the McGeer criteria. Those are surveillance definitions. What I'm hoping you're also familiar with are the Loeb criteria, and these are the minimum criteria for starting antibiotics in nursing home residents. When it comes to thinking about starting antibiotics for people with urinary issues, if they have dysuria, that's enough that you can go ahead and start. I mean, get the diagnostic test so you know what you're treating, but go ahead and start. Or if somebody has 2 or more of the following: fever and shaking chills, urgency, new or worsening urgency, flank pain or suprapubic pain, new or worsening urinary incontinence, and gross hematuria. We're going to come back to these a little bit as well. There are lots of reasons for the signs and symptoms that are part of the Loeb criteria. and including lots of reasons for cystitis. So somebody, for example, might complain of dysuria, and it's totally fine to try antibiotic once and see if that works. But if it doesn't, then we need to start thinking about other diagnoses. So sometimes when we talk about dysuria, what we really are noting is that there's an occasional tingly or funny feeling. Sometimes people have urinary retention, and it can look like urinary incontinence because there's overflow incontinence at that point. They can have a change in mental status or behavior or functional status. This is 99% of the time unrelated to urinary anything. Dark or funny smelling urine is not an indication of a UTI. What is it an indication of? And let me have you guys please put your responses in the chat. That we're going to make this interactive. So when someone's got a dark or funny smelling urine, what's going on there? Yeah, dehydration, you got it. That's exactly it. And so the answer is not Cipro, the answer is fluids, right? Falls, not a urinary tract issue, unless of course they might be running or trying to rush to get to the bathroom in time, but that's still not a urinary tract infection. That's just a urinary issue. And then family or resident request, also not a UTI. It means that we've trained them really well over the years. All of us have, not just me, in terms of, something might be wrong. So maybe it's a UTI. When we have to work very hard as a culture, as a medical culture, to get past that thinking. When we think about signs and symptoms of infection, there's some pretty typical ones. Fever is a no-brainer. People that have a chest infection will have cough, sputum production, pleuritic chest pain, not cardiac chest pain. People with urinary issues will have dysuria, frequency, urgency, hematuria. GI issues, it's like the asparagus in the chat. Yeah, that's true too. Sometimes multivitamins also can make your urine smell funny. For GI issues, nausea, vomiting, abdominal pain, diarrhea, a whole host of things can go wrong with our bellies. And then for skin issues, it's erythema, so redness, swelling, pain will point to a skin issue. So the only, except for fever, everything in here localizes to a specific syndrome or specific anatomic involvement. Fever is systemic. Let's think about atypical signs and symptoms that we're always told about for older adults.
So awesome.
I'm sorry, I'm getting a little bit of feedback. So poor appetite or anorexia, functional decline, falls, incontinence, change in mental status, or delirium. These are all considered to be atypical signs and symptoms of infection for older adults, but here's the problem. These are all nonspecific. None of these localized to any one area except urinary incontinence, and we all know that there can be lots of reasons for urinary incontinence, a lot of which are related to mobility. So these are not specific, and there's other reasons for them that go far beyond infection. Infection is least, or at least not very high among the rankings here. Let's first tackle change in mental status. So there's a lot of ways to think about this. And one organizational rubric, I guess, is that we can think about depression, which is chronic. We could think about dementia, which is chronic. And I had recently a geriatrician teach me, which I loved, that we think about dementia as chronic brain failure. Delirium is acute, and though it can go on for days to weeks. And delirium, one way to think about that is as acute brain failure, and it means that we can have, just like kidney disease, acute on chronic failure. And then finally there's coma, and that's a whole different issue and a different talk. So when I think about depression and dementia, those are a change in behavior that we notice in our residents. It's bothersome, but it doesn't get us thinking about infection. It gets us feeling sorry for the person, maybe if, depending on the dementia, behavior is a little frustrated. Delirium, though, that's a change in level of consciousness. That is alarming. An infection is a common cause of delirium. But delirium has really specific criteria. This is not that someone's acting funny. This is an acute change. And you've seen this and you've probably reacted to it at some point. So there's this fantastic confusion assessment method that people can use for assessing deliria. And like everything else these days, there's an app for that, which is fantastic. So the app is the I don't know if you can see my mouse, but this brain with the gear and the question marks, that's the app symbol. It comes from Penn State. It's called the UB Cam app. It's free on Apple and on Google Play. And it goes through the confusion assessment method where we look for acute change in mental status with a fluctuating course and inattention, combined with either disorganized thinking or an altered level of consciousness. Download it, try it. If you've got small kids, try it on your kids. If you've got an older adult that you want to try it on at home or at work, try it on those too. Try it on yourself one morning after you've slept in. It's very easy to use. It's right there on the phone. And what I really like about it is that this can be done. I can do it today on a patient or a resident. And then when Teresa's on service tomorrow or Liz is on service on Thursday, they can also repeat the score and write it down. And we can see how someone's changing or not changing over time. Okay. Let's move on. So I should stop. Are there questions about this? Anything that we've talked about so far? If there are, please put them in the chat. I think there's a lot of people on the call. I'm not opposed to a conversation, but chat is a little easier at the moment. Okay, I will. Oh, thanks for putting that in the chat. All right, so now everybody can find it. Excellent. Okay, let's talk about the urine that we catch or that we study. So it's always the idea of a clean catch, right? So here's the process. Sit down, cleanse again, hold the labia apart or pull the foreskin back, start to pee, stop peeing, which is really hard to do, position the container, start to pee again and collect the urine, and then get the lid on the container without touching the sides or the inside of the lid. This is not easy. I and I bet a whole bunch of other people on this call have had to do it when they're pregnant. It's been a while, but I had 2 good hands and 2 good hips and 2 good knees, and this was still a challenge. It's really hard for older adults to do this well, especially our ladies. So, recommendations for getting a good urine. Suggest a shower or a bath before getting a urine. For men, and this is the only time you'll ever hear me say this, you can do a short-term condom cath and then get the urine from the bag. Oh, I don't like doing that, but this is what we can do. For women, it's an in and out catheterization sometimes, and that's really awful. It's uncomfortable to begin with, and especially for our female population that's maybe a little bit confused or a little bit demented, this feels like an assault, and it's just unpleasant. If there already is a urinary catheter, then we've got to change the entire sample collection before, sorry, the entire sample collection system before getting a sample, excuse me. And then the samples have to be stored in the refrigerator until they're taken to the lab. And that sounds like a no-brainer, but how often has it happened where you leave somebody with a cup in the morning and then at 2 o'clock in the afternoon when you happen to go by again, there it is on the bedside table or on the bathroom sink, and you have no idea how long it's been sitting out at room temperature with bacteria dividing, and all at once it looks like they've got a UTI when maybe they just had poorly stored urine. I feel strongly that it is so much easier to get a good blood culture than it is to get a good urine. And yet, we take blood cultures very seriously. We take urine cultures far too seriously, given how poorly collected that they are. To that end, we need to make sure that we help families understand it's not as simple as, well, we'll just check a urine. I would so much rather get blood cultures or even a good sputum culture than trying to get a good urine culture. So sometimes these are not worth the containers that they're collected in. So once we have a urine culture, let's talk about interpreting them. Let's assume it was a good one. Clean catch of someone who just had a bath. an actual real clean catch, a midstream urine catch. So here's how the diagnosis goes. So we've got an acute uncomplicated urinary tract infection, sorry. The urine culture should have greater than 1,000 bacteria. Sorry, greater than 100,000 bacteria, or 10 to the fifth, and no more than 2 species. And then we have to have a clinical signs or symptoms that go along with this. So dysuria, or the things that we talked about at the start of the session, frequency, urgency, suprapubic pain, incontinence, gross hematuria. By the way, gross hematuria is common in young women. I don't see it very much in older adults, and I want to say never, unless there's already a urinary catheter or some other instrumentation in place, and then it's trauma that's caused the problem from the catheter and the balloon bumping up against the friable mucosa on the bladder. I'm not saying you can ignore gross hematuria, but I have my opinions here, and it is my opinion. So let's now go to the diagnosis of asymptomatic bacteria, which Liz mentioned earlier. So the urine culture shows greater than 100,000 bacteria and no more than 2 species, which looks a lot like, and it's the exact same as it is for the acute uncomplicated UTI on the first row. And then it's no signs that are referable to the urinary tract, which means that we can't use urine cultures to tell us whether or not someone has a UTI. We have to go by signs and symptoms. Do you notice what's not in here? There's a test that we commonly use, not part of the diagnostic criteria. Go ahead and put it in the chat. It's not blood cultures either. Yeah, it's the UA. There's no urinalysis in here. There's no crying in baseball, and there's actually not urinalyses that are used to diagnose a UTI, which I know is like a huge, I don't know, it might be a revelation, or it might sound like heresy to some of you. So when we think about interpreting urine cultures, it's okay to have a dirty urine, and the difference is whether we've got an unhappy pig pen or a happy pig pen. He has a dirty urine in both situations. It's how he feels. So let's talk about UAs. Here's the heresy. So Luke esterase on a urine dipstick or other test is the same as white blood cells. That's what it's indicative of. Nitrites are indicative of gram-negatives, specifically Enterobacteriaceae in the urine. So this is the E. coli, the Klebsiellas, all the other gram-negatives that we deal with. Gram-positives actually don't show up as nitrites in the urine. But this tells us nothing about acute cystitis. So why do we even bother to get UAs? One, it's habit, I think, unfortunately, but there actually is value in them. I won't go through the math here. I used to be able to, but no longer. But here's the take-home message on the math on this. The sensitivity of a positive urinalysis is 100%. So if a UA comes back looking positive, then yeah, it can, everyone who has a positive UA, everyone that has a urinary tract infection has a positive UA. Specificity is 20%. So a lot of people that have a positive urinalysis don't have a urinary tract infection. So what's the useful part of this? It's the negative predictive value. When we have a negative urinalysis, that rules out UTI. A positive urinalysis does not rule in a UTI. This is important. We have to flip our thinking. It's like thinking about D-dimers and using those to diagnose a pulmonary embolism. A positive D-dimer doesn't mean that someone has a PE. It means that they could have one. And a negative D-dimer is reassuring. A positive UA does not mean UTI. It means it's a possibility. A negative UA rules it out. Okay, not heresy. There actually is evidence to support my views here. Potentially cost saving. That's a great thought. And yes, don't culture if the UA is negative. That's fantastic, even better. And I don't know that Liz touched on this. She talked about antibiotic stewardship, but not necessarily diagnostic stewardship, which is what this brings to mind, this comment about could we save costs by only doing urine cultures on positive UAs. The threshold in many labs for taking a UA and making it become a urine culture is based on the degree of leukoesterase or white blood cells in the urine. And some people say if it's over 10 white blood cells per high-powered field, that's enough. I don't think we have good limits on this and know what the right number is. And it may not really be a number, it may be the symptoms. But in places that have had a higher threshold for when a urine study should reflux to culture, they see lower rates of UTIs diagnosed, lower rates of antibiotic use, and no increase in patient harm. So this is a great idea. Raising our threshold for deciding which patients we should send urine cultures on is a good idea. It increases our positive predictive, our pretest probability. And we can talk about that more if that wasn't clear, or there's other questions on this. So let's talk a little bit about catheter-associated UTIs. So here the criteria are somewhat different and a lot more relaxed. So here is only 1,000 colony-forming units of bacteria and a symptom. So the symptoms can be fever, rigors, change in mental status, malaise, and lethargy. But the context for interpretation here is that all the other causes for this need to be ruled out. And I think this is where we often fall short. I think we're quick to say, oh, catheter-associated UTI, because we've got this positive urine culture from the catheter, that must be the cause of all the problems that this person's having. We are obligated to try to rule out the other things, because then we're not only not responding to we're missing the chance to treat what's really causing the problem. And missing a pneumonia or missing a medication reaction is not good. Things that localize to the GU tract do help rule this in a much more rational way. So flank pain, costovertebral angle or CVA tenderness, acute hematuria with the same caveats that I mentioned before, or pelvic discomfort. And then if the catheter has come out recently, then we're back to the things that we think about for non-catheterized patients. So dysuria, increased urinary urgency or frequency, or suprapubic pain and tenderness. So the surveillance definitions, like the McGeer criteria, and the clinical definitions for CAUTIs do not add up. These are different, and it's very frustrating. So the laboratory criteria, this is a great study that was published, 10 years ago now. They looked at people that had a urine culture that met the criteria for a clinical CAUTI, and so either 10 to the 5th bacteria or greater than 10 to the 3rd, and someone that still had the catheter in place. And then symptoms. So fever, suprapubic tenderness, or CVA tenderness, and took it from there. And they went and compared among 85 patients who met the surveillance definition, all of whom had a fever. Of those, about half had a clinical CAUTI, and that the patient was given a diagnosis and treated for UTI, and about half had an alternate source of alternate source for the fever. So another reason that was not UTI related. So what we're calling UTI, or what we're calling CAUTI specifically in nursing homes based on the surveillance definitions on the McGeer criteria, or on the NHSN criteria, which are pretty much the McGeer criteria, are not the same as what's going on clinically. And that can be hard to work through with patients and within our own minds too. Questions on this? Okay, if any more come up, put them in the chat for me, please. Okay, and now we're getting to another interactive part of the presentation. And this is used to be nobody got this right, and now almost everybody does, which I'm really glad to see. So we're going to interpret urine culture results. So we've got a good urine culture. We have someone that came in with, it really hurts when I pee, and I'm not able to make it to the bathroom in time, and I feel like I always have to go to the bathroom. So that's dysuria, urgency, and frequency. And we get their urine back, and we've got this amazingly pan-susceptible E. coli. So it's susceptible to ampicillin, cefazolin or Keflix, Cipro, Bactrim, nitrofurantoin, and Amsulbactam. So the question is, which antibiotic or antibiotics would you like to prescribe for this person? What should we treat him or her with? Go ahead and put your answers in the chat, and we'll talk through them one by one, or maybe in groups. But and it's okay to just go ahead and just shout it out or put it in there. I won't pay attention to who puts their thoughts in. I won't pay attention to your name. How about that? Oh, and while the chat's being populated here, I should mention that we've got the interpretation there as all S's for susceptible, and those numbers represent the minimum inhibitory concentration of the antibiotic, or MIC. Okay, so I'm seeing ampicillin, Bactrim, Cipro, nitrofurantoin. Yeah, it's hard to know because they will all work, right? Because it's all susceptible. So let's go through these one by one. Or actually, we'll go through them in groups. So ampicillin and cefazolin. Both are good choices here. It's actually not ampicillin. It would be amoxicillin in this case as the oral version of it. And cephalexin as the oral version of cefazolin, but both are good choices. They're relatively easy to take. They're narrow spectrum. They are excreted through the kidney and into the bladder. And we know this because we have to adjust those doses for people that have renal insufficiency. So these are both good urinary choices. Let's go to Bactrim next, and nitrofurantoin. Both of those are also good choices because they are also good UTI agents. And nitrofurantoin in particular only goes into the bladder. There's no systemic absorption of it. And I don't quite understand how that works, but it does. And it gets excreted into the bladder and does wonderful things there without causing problems in the rest of the body. So it's not good for pyelonephritis, but it's excellent for acute cystitis. And Bactrim, while it does have systemic absorption, is also really good for a lot of acute cystitis pathogens. And they're also relatively narrow spectrum. So those are also good agents to choose. I am less keen on using Amsulbactam or Amoxiclav or Cipro. They'll both work, but they're really broad spectrum and they cause a lot of collateral damage that we don't necessarily need to have happen. And both will increase the risk of someone to have increased risk of C. difficile and of getting a drug-resistant pathogen, of acquiring one. And Cipro or fluoroquinolones especially come with a whole host of side effects, including change in mental status, hypo or hyperglycemia, and you can't always predict which way they're going to go. And then the Achilles tendon rupture and increased risk for a ruptured aortic aneurysm. Fluoroquinolones have a black box warning on them for some of these side effects. So where some people get caught up in this and where they are over-interpreting or overthinking it is these numbers here under the MICs. These are not indicative of how good the antibiotic is at all. And I've had people say, but the Cipro has the least inhibitory concentration, so that must be the best to use because you don't need as much of it. This is like trying to compare the blood pressure lowering activities of lisinopril versus Lasix versus hydrochlorothiazide. Different agents acting in different ways and doing different things. And for antihypertensives to our bodies, for antibacterials to the bacteria. We can't compare them. And so the take-home message here is that, oops, sorry, I went too far. ID physicians do not do math. Neither should you. We go by the S's and the R's and the I. And I in ID world means resistant. I is for intermediate, R is for resistant, S is for susceptible. By the time I'm looking at MICs, these are people that are usually in the hospital, are really sick. And at that point, I'm trying to like do checkerboarding and crazy things to find something that works. And I'm hoping that you don't have to face that in long-term care. Okay, so selecting antibiotics. Nitrofurantoin is great, 5 days of therapy. It can be given to people with a creatinine clearance of 30 or greater. It's not good for pyelonephritis. And that creatinine clearance of greater than 30 is real. It has been, there's lots of endorsement for it. The concerns for creatinine clearance and nitrofurantoin came from when people were on this for like months and years on end. It's fine for a few days. Bactrim, 3 days. It causes a real increase in potassium. So if somebody already has a high K, try to avoid it. It causes an increase in creatinine, which is cosmetic. It goes away when the Bactrim goes away. And then the beta-lactam agents, this is amoxicillin and Keflex, 3 to 7 days. These are narrow options, and I like these as well if I can't use nitrofurantoin. Other oral agents, and I put them in gray because I'm trying to discourage their use. Fosfomycin, it's a good drug. I like it, but I don't want anyone to use it, including me, because it's an agent of last resort for MDROs. It's 1 to 2 doses, and 1 dose lasts 3 days. It's not good for pyelonephritis, but it's an agent of last resort. So if it's a matter of do I hospitalize someone or send them home on fosfomycin, I go with a fosfomycin. If it's a matter of, nitrofurantoin or phospho, I go with the nitrofurantoin or the 4 times a day Keflex. I'd rather inconvenience someone than start making that drug no longer useful. And fluoroquinolones, I've already expressed my strong feelings about them there. They're just, I don't like to use them. There's a lot of downside, not always upsides. Just some other thoughts that I've kind of learned through the years. So the oral equivalent of ampicillin is amoxicillin. The oral equivalent of cefazolin is cephalexin. Some people will use cefuroxime. I prefer cephalexin or Keflex. The oral equivalent of amsulbactam is, in most cases, amoxicillin. Sometimes we'll see antibiotic susceptibility reports indicating tetracycline, and that is sometimes its own drug, which I don't quite understand. The actual agents are doxycycline and minocycline. Doxycycline is the one that we most commonly use. Pathogens in the urine. Whenever I see Enterococcus in the urine, I do not get excited. I kind of get annoyed, actually, because it just doesn't do anything. It's just there because it came out of the other orifice. It's fine. It's a bad roommate, but if it's in the bladder and the person's fine, I do not get upset about this at all. Enterococcus in the blood, I take seriously, but in the bladder, if they're not symptomatic, I let it be. Staph aureus in the urine, I always get excited about, no matter what, even if they're not grossly symptomatic. And that's because half of the time with Staph aureus, it's coming from the inside out. Everything else that causes a urinary tract infection or asymptomatic bacteriuria comes from the outside in. And this is why women tend to get more UTIs or concerns about UTIs than men, because we have a much shorter urethra. It's just anatomy. Okay, let's talk a little bit about antimicrobials for people that have severe dementia. This was a fantastic study that looked at nearly 100 or over 100 residents in nearly 200 episodes of suspected UTI. These were mostly old white women, and they had really impaired cognitive status to the point where they had like 200 words left vocabulary-wise and didn't recognize their loved ones when they walked in the room. 28% had a fever. 80% had a positive UA in culture, and only 16% met the minimum criteria to start antimicrobials. And this is what happened to them. This is a Kaplan-Meier curve, and so we're looking at mortality for the year after someone was diagnosed with a UTI, and so that as the line goes down, their survival is going down. So the top line is IM or intramuscular antibiotics. I do not know why it's that high. I have no explanation for that. The bottom line are people that were sick enough they wound up getting IVs or went to the hospital to get their urinary issues or whatever it was treated. The two lines I want to draw your attention to are the ones in the middle. There's the no antibiotic line and the oral antibiotic line. And for all these people who had a low pretest probability of having a urinary issue and were given oral antibiotics, it didn't do a darn thing to improve their survival. It's the same curve between people that did and did not get antibiotics, oral antibiotics. So instead of running to the shelf and seeing what we can prescribe, there's been a lot of push to try active monitoring. This is an active process. We are doing something. It's more frequent vital signs, it's oral hydration, it's assessing for pain, for changes in medicine, for other reasons why someone might be not acting like themselves, like a bad night's sleep or constipation. And I won't belabor this, but there is an active monitoring order set that you can access easily. The reference is here, and I'll still at the end of my slides. The take-home message from the active monitoring order set is that it closes the loop. I have a concern about a resident. I'm going to call the person on call and let them know about that. I'm going to provide them with information ongoing so that we can see how the person is doing later. So it's a ongoing process, not a one-time fix it and forget it approach. Let's go back to Mr. N. And I realize that we're getting close on time, so I will not make this part interactive. So the nurse notes dysuria here. And then 2 days later, when the urine culture comes back, he's prescribed an antibiotic. So what's missing here was a reassessment of the resident. Because as it turns out that by that 2 days later, he wasn't as bothered by whatever was happening in his bladder. And the dysuria wasn't really so much dysuria as it was a funny feeling for a guy that's on narcotics and has lower urinary tract syndrome or LUTS. So nonetheless, he got his antibiotics, and then a few days later, he was noted to have urinary retention. And he was getting intermittent straight cast. That was not comfortable for him, and so someone appropriately put an indwelling Foley to help address the urinary retention. He was having behavioral issues around pain, and there was this night coverage note, and you can't make this stuff up, that large volumes of urine may exacerbate chronic kidney disease and UTI. It's actually backwards, but it's okay. It's okay. So he finished the cefuroxime on the 18th. Somehow the provider attributed urinary retention to the UTI. Again, backwards. When we have UTIs, we've got frequency and urgency, not retention. They stopped oxybutynin. That was a good move. And they started to address his pain issues, the narcotics issues, and actually some constipation issues for him. The catheter came out a few days later, and then someone started him on tamsulosin to help address the prostate issues that he was also having, and things, got better. So when we're thinking about urinary tract infections and we hear that somebody has dysuria, there's other things that can not be acute cystitis that are causing that dysuria. For men, it's an enlarged prostate or LUTS, where it's just they've got funny feelings, physical feelings, not emotional feelings, but just something's not right. For women, it can be a yeast infection, and that happens a lot for older ladies, and it feels the same way. It feels like burning. Urgency can be due to recent instrumentation or urgent continence. Flank or suprapubic pain might be spinal cord issues, muscle spasms, shingles, GI issues, renal stones, which are a big one. New or worsening incontinence may relate really to mobility. Again, concerns for stones. People may have a neurogenic bladder. There might be pelvic floor weakness. Gross hematuria, we've talked about the urinary catheters. It can also be prostate issues, again, stones, renal or bladder cancer, and that's important to keep in mind. And sometimes medications will look like that they don't necessarily cause blood, but they can make the urine change color, and that can be alarming. Some medications, if someone's over anticoagulated, can also lead to blood in the urine. And then finally, when it's fever or shaking chills, UTI is not the first place I'm going. I'm looking for a systemic infection, and it may be bacteria that have caused a bloodstream infection that came from the bladder, but nonetheless, I'm not stopping my thinking at the bladder. So the take-home message is, it's okay to have a dirty urine. It's okay to have a positive urine culture. It's okay to stop antibiotics. Please do not do tests of cure. Don't borrow trouble. Try active monitoring before trying antibiotics. And 7 days of antibiotics in nursing homes in general is a pretty long course for an infection that arose in the nursing home. I will stop with a nursing home haiku and get a little sip here of iced tea while you are counting syllables. And I look forward to questions. Thank you very much. Oh, thank you for the applause. Appreciate that. Yes, I'm assuming so. Therese, you have my permission to share the slides. And after this particular slide, there's more. There's not available just yet, but coming to a website near you in October of 2025. No promises. There's toolkits for MRSA prevention. The toolkit for long-term care specifically focuses on skincare and bathing and preventing actually pressure ulcers or pressure injuries, sorry, as a way to prevent MDRO infections in general. And then, oh, okay, thank you for putting those in the chat. There's also, and this is available now, a different toolkit. These were both through AHRQ. Oh, thanks, Christy. Yeah, they are really, it's pretty nice. So these are resources that you can apply across settings, including long-term care, and there's specific antibiotic use protocols about treating UTIs or respiratory tract infections or skin and soft tissue or C. diff. And there's a couple more resources. And I saw a hand up. Therese, go ahead, please.
Yeah, I think one of the comments that I've heard a fair bit during infection control consults for long-term care is the struggle that staff have when they're insisting that their loved one has a UTI. Can you provide some guidance on how to address that with family members?
Yes, I'd be happy to. It's not easy. We as a healthcare system have trained people for years and years and years that, well, it could be a UTI. And along with that is the idea of, well, we can do an antibiotic. They don't cause any problems. They don't hurt. But the fact of the matter is we know that they do hurt. And what's even harder to grasp is that they don't hurt right away, and they don't always hurt in obvious ways. So they can cause problems, but it's down the road. And trying to look backwards and say, it was that antibiotic on that day that led to my mother's C. diff is hard to do. Or it was this antibiotic when I was having this episode of whatever it is that led to me having a multi-drug resistant pathogen. Like nobody makes that connection. I've tried to do it in research, and even then, it's really challenging to be able to draw a straight line between one antibiotic exposure and one adverse event like that. Side effects, we definitely can point to, like rashes, thrush, things of that nature that are more immediate. So this is one of the things we can talk about with our families. The other is to say, look, the last 3 times we did this, you're right. We gave your mom an antibiotic and she perked up after a few days. But we didn't just do an antibiotic. We did other things. We made sure we talked to her more. We checked her vital signs more. We made sure that she wasn't hurting. We looked at her medications. These are the other things that we did that don't mean prescribing a really powerful medication. So before we start doing a really powerful medication that can have down the road consequences, let's first try these other things that are meaningful and helpful, but don't have current or immediate or down the road consequences. Let's give her some more fluids. Let's make sure she gets some rest. Let's talk to her and find out what else would be going on. Let's see what medications that we recently started or stopped or changed a dose of to see if that's an influence. Um, so that's the thing you can try to turn to. And then you can also tell them, look, we're going to monitor her vital signs every 6 hours or every 12 hours for the next 2 days and see how things go. And if she gets a fever or if something else changes, we know exactly what to do. We know what to start. We've got that plan in our back pocket. We'll keep it there until we're ready to pull it out and use it. And maybe we don't need to. Maybe we can do something simple to help her feel better, which is what we all want to make happen. In this in this toolkit for antibiotic stewardship, there are resources to help with those dialogues and interactions with families. Okay, and I see Teresa's popped back on, which means I've talked too much. And you're on mute.
No, not at all. Wonderful. This is just amazing information. We have like 2 minutes left if anyone has any other questions.
And we've just spent the whole hour talking about pee, so you can ask me anything.
I don't
You're
want to
very
steal
welcome.
anyone's question times, but just to address the last question a little bit too, I think we've provided a tool, and I can share it with Therese. We worked with Project Frontline to provide a tool. I think one of the really effective things that a lot of long-term care facilities have done or that we've supported is setting expectations ahead of time, right? Like at admit or, at some point before anyone is sick, before there's a suspected UTI, sort of like, here's our philosophy of antibiotic use. Here's how we approach it so that when someone's not feeling well, when I'm worried about mom, I can kind of remember that because, after you're worried about a loved one, it's a tougher conversation to have. But yeah, I think the other really important thing is Dr. Jump mentioned that like, that active monitoring, that we're not just saying like it's not a UTI, so we shrug our shoulders and don't take care of mom anymore. Like we're continuing to monitor. We can change the plan at any time. I think those are really important messages.
That's great.
That's fantastic.
Thank you. Yeah.
And then there's a question about how this translates to acute care settings. I think for older adults, almost everything that I covered in here for long-term care applies to acute care as well. Where we often have a problem with acute care is in the emergency room, which is a point of entry for a lot of people. And there's a kind of a it's common to see that people get prescribed or diagnosed with UTIs in the emergency room based on the results of a urine culture and someone acting funny. And it's hard to stop those when someone's admitted, but it can be done. And it might be something where maybe if you're in a smaller hospital, that it can be tried to say, hey, if you're going to admit them, don't start the antibiotics for a UTI down there. We'll do it on the floor. Give us 6 hours to see if there's something else going on. And then from there, it'll be the person will be out of the ED and you can do what you want.
Okay, well, we're a little over time. Thank you both, Liz and Robin Jump. Thank you. This was amazing. And I will be sending a link out to the recording and the PowerPoints and the links that were referenced during the presentation. So thank you everyone for joining. Thank you, Dr.